Welcome to the Culture of Healthcare Evidence-Based Practice. This is part 3 of our series. In this lesson, we'll explore the expectations and responsibilities of professionals working in healthcare environments. We'll examine how care is organized across different practice settings, the critical importance of privacy laws, and the professional and ethical challenges that arise in day-to-day practice. And because healthcare is a team effort, we'll also highlight the role of clinical engineers whose work with medical technologies and safety systems ensures that evidence-based care can be delivered reliably and effectively. By the end of this session, you'll have a clearer understanding of how the culture of healthcare shapes professional behavior, decision making, and the safe use of technology in patient care. Culture of Healthcare explores the expectations and responsibilities of the professionals working in healthcare environments. It explains how care is organized within different practice settings, outlines the importance of privacy laws, and addresses the professional and ethical challenges that may arise in the workplace. I want to thank you for tuning in, and let's get started. Let's look at the objectives for evidence-based practice with clinical engineering perspectives. And in this session, we will be looking specifically at explain how EBM or evidence-based medicine can be applied to intervention studies, including the phrasing of answerable questions, finding evidence to answer them, and applying them to given clinical situations. For engineers, intervention studies include clinical trials of new devices, pilot testing of equipment in hospital units, or simulation-based training. Engineers contribute by analyzing performance metrics, identifying unintended consequences, and helping clinicians interpret whether the intervention is truly effective in their setting. We'll look at how interventions are studied and evaluated in evidence-based medicine. So interventions are the actions we take to improve health or prevent disease. They can include drug treatments, diet changes, surgery, or even complementary and alternative therapies. When evidence-based medicine is applied to interventions, the central question is, does this action truly benefit the patient? The most reliable evidence comes from a randomized controlled trial, an RCT, which we'll mention throughout this series, or better yet, from a meta-analysis that combines multiple RCTs. In an RCT, patients are meant to be similar in every way except for the intervention being tested. That way, differences in outcomes can be attributed to the intervention itself. And of course, in practice, this perfect condition is hard to achieve, so we must critically evaluate whether studies maintain this standard. Relating this to clinical engineering, a clinical engineer might not prescribe medications or perform surgery, but interventions also include technology-based solutions, like a new infusion pump, an updated imaging protocol, or a redesigned alarm system on a ventilator. Just like a drug trial, new medical devices and technologies must be evaluated. Does the technology improve outcomes? Does it reduce errors? Does it create unintended consequences? For example, if a hospital introduces a new ultrasound machine, evidence-based practice would ask, does this device improve diagnostic accuracy compared to the old one? Does it reduce the time to diagnosis? Does it change patient outcomes? In some cases, a clinical engineer may be part of a research team designing or analyzing device studies, where RCTs or comparative effectiveness research methods are used, would be in these types of environments. Um, so, interventions in health care aren't just about treatments like drugs or diets. They also include the tools and technologies developed, maintained, and assessed by clinical engineers. Why randomized controlled trials matter? RCTs. RCTs are considered the gold standard for evaluating interventions because they reduce bias. When participants don't know which treatment they're getting, the power of suggestion or personal belief can't distort the results. So, an example would be vitamin C and the common cold. Many of us know someone who swears that vitamin C prevents colds. They'll say, "Since I started taking vitamin C, I never get sick." But when researchers put this belief to the test in more than 30 RCTs, the results were clear. Once bias was eliminated by using placebos, there was no difference in how often people caught colds. Second example could be women's health initiatives. Before the Women's Health Initiative study that was led by Jablowski and colleagues, it was widely believed that postmenopausal estrogen replacement therapy helped reduce heart disease and cognitive decline. A large, well designed RCT showed the opposite, overturning years of clinical practice that were based more on assumption than evidence. A third example would be lidocaine for heart attacks. In the 1980s, lidocaine was routinely prescribed for heart attack patients under the belief it would prevent fatal heart rhythm problems. But the Cardiac Arrhythmia Suppression Trial, or CAST, revealed that not only was lidocaine unhelpful, it was actually harmful. This RCT stopped the practice almost overnight. And the lesson? RCTs are valuable because they focus on patient oriented outcomes like survival, quality of life, or symptom reduction, not just assumptions or lab findings. A fourth example would be radiation oncology trials. In one review, researchers found that new radiation therapies were just as likely to fail as succeed. This shows that new isn't always better. Every new approach, whether a drug, therapy, or technology, needs to be tested in an RCT to prove that it is truly superior. And where does this relate to clinical engineering? Again, we have the word clinical in front of our name. So we should know what RCTs are and how they're conducted, and probably do a few of our own. So just as medications that which get all of the spotlight, new medical devices and technologies can create excitement. Engineers, vendors, and clinicians often assume the newest device must be an improvement. But history shows that this isn't always the case. For example, a smarter IV pump might reduce some errors, but introduce new types of programming mistakes. A new diagnostic ultrasound system may offer better imaging resolution, but an RCT or equivalent device trial is needed to show whether it actually leads to earlier or more accurate diagnosis. Alarm fatigue interventions, like reducing non actionable alarms, can be evaluated through an RCT like study to prove they improve patient safety without missing critical alerts. And so clinical engineers have a role in supporting these evaluations, whether by helping design studies, collecting performance data, or translating device metrics into patient centered outcomes. Now, another example, if we're focusing more on the technology and on the engineering side, would be smart infusion pumps and medication safety. So, in the early 2000s, smart infusion pumps with drug libraries and dose error reduction software were marketed as a solution to medication errors. Hospitals rushed to adopt them, believing they would dramatically improve patient safety. However, when these devices were put to the test in randomized trials and observational studies, the story was more complex. Yes, they prevented some overdoses, but they also introduced new risks, confusing interfaces, alert fatigue, and workarounds were where staff had bypassed safety features. Now, the confusing interfaces leads to something I mentioned in a previous recording, which is cognitive load, which deals more with the engineering psychology of device design, which I'll hint on here and there, but that is not the purpose of this lecture. But again, we're psychology and sociology for healthcare. In this case, engineering psychology, clinical engineering psychology, and sociology overlap. But back to this lesson, the RCTs revealed that smart pumps alone were not a cure all. They work best only when paired with training, policy changes, and system redesigns. And the lesson was just because a device is smarter doesn't mean it automatically improves outcome. And yet, still another example, ultrasound for central line placement. So, for decades, central venous catheters were placed by landmark techniques relying on clinicians' anatomical knowledge and palpation skills. Many believed this method was reliable enough. Then came studies including large RCTs that compared traditional blind insertion with ultrasound-guided insertion, and the results were super clear. Ultrasound guidance reduced complications like arterial puncture and pneumothorax and improved first pass success rates. And so today, ultrasound guidance is the evidence-based standard for central line placement. This shift was driven not by assumption, but by RCT evidence that linked a device intervention directly to safer patient outcomes. And yet, a third example, which is on the news today, at least within our small circles, alarm fatigue. So, alarm fatigue and smart alarm algorithms. So, hospitals once believed that more alarms equals more safety. Um, we see now that is not the case. Every possible threshold was set to trigger alerts, filling ICU environments with constant beeping, but staff became desensitized, which is again another problem with that can be explained through psychology. Had they had engineering psychologists in the team, it would lead to what was inevitably alarm fatigue and tragic cases where critical alarms were actually missed. In response, vendors introduced smart alarm algorithms that filter out non actionable alerts. But were they safe? A controlled trial compared ICUs with traditional alarms to those with smart alarm systems. The RCT showed that nuisance alarms decreased by 50% without increasing missed true alarms. So nurses reported lower stress and response times improved. So this evidence shifted practice. Fewer alarms can actually mean better safety if supported by good engineering and testing. And another example, again, just related to clinical engineering, new radiology display monitors. So radiologists once believed that newer, higher resolution monitors would always lead better diagnostic accuracy. After all, clearer images should mean better reads, right? So RCT style studies tested this assumption by comparing diagnostic accuracy on standard monitors versus newer, higher resolution displays, and the findings were mixed for certain subtle findings like microcalcifications and mammography. Higher resolution monitors were improved detection, but for other routine tasks, accuracy wasn't changed at all, suggesting that investment didn't always pay off in patient outcomes. So the lesson here is not all upgrades are worth it. Evidence must show where new technology makes a meaningful clinical difference. Quality of evidence and the inverse effect. Over time, researchers have noticed an interesting pattern. The higher the quality of the study, the smaller the apparent treatment effect. In other words, when a study is very well designed using proper randomization controls and blinding, the results tend to show less dramatic benefits than weaker studies suggest. And this makes sense. Poorly designed studies often exaggerate results, while rigorous RCTs give us a more realistic picture. Another important finding, low quality evidence is more likely to be overturned. Many interventions that looked promising in early, uncontrolled studies were later disproven when tested in well designed RCTs. That said, observational studies still have value. If carefully planned and executed, they can provide evidence that's just as reliable as RCTs, especially in cases where randomization is not ethical or feasible. And if we relate this to clinical engineering, the inverse relationship in devices. So, new medical technologies often look more effective in early pilot studies or case reports than they really are. For example, an initial observational study might claim a new ventilator mode drastically reduces mortality, but once tested in a multi-center RCT with hundreds of patients, the effect might shrink or even disappear, overturning device beliefs. So early studies of certain alarm reduction strategies suggested massive improvements in safety, but when tested in controlled environments, the effect was smaller, reminding engineers to be cautious about early claims. Let's talk about the role of observational studies. So sometimes RCTs aren't practical in engineering. You can't always randomize patients to use this infusion pump versus don't use the pump. Instead, large scale observational studies like analyzing thousands of log devices events across hospitals, can give evidence that's just as strong, provided the study design carefully controls for bias. And a practical takeaway for clinical engineers is when evaluating new devices, don't just rely on vendor white papers or small case series. Look for RCTs or well designed observational studies that measure patient centered outcomes. Strong evidence protects patients and helps hospitals invest wisely in new technologies. The history of RCTs. So, RCTs are such a staple of modern healthcare that it's easy to forget they had to be invented. Their history is fascinating. One of the earliest examples, often cited, is from Dr. James Lind. He's a British naval doctor in the 1700s. And at the time, sailors frequently developed scurvy during long voyages. Lind conducted a simple but powerful experiment. He gave citrus fruits such as lemons and oranges to some sailors while others received no citrus at all. The results were unmistakable. The sailors who ate citrus remained healthy, while those without it developed scurvy. We now know this was due to a vitamin C deficiency, but Lynn's experiment was a turning point in showing how systematic trials could guide medical practice. The first true modern RCT was conducted in the United Kingdom in the 1940s. Researchers studied tuberculosis treatments by comparing streptomycin. That was one of the earliest antibiotics they compared that with a placebo in the trial, and the trial clearly showed streptomycin's superiority and became a landmark example of how rigorous study design could change clinical practice worldwide. And always, we must relate this to clinical engineering. So the parallels are in device evaluation. And just as Lynn compared citrus to no citrus, clinical engineers often test new devices or configurations against some standard practice. So, for example, a new alarm management system might be tested in one ICU while another unit continues with standard alarms, and outcomes are compared. So, first, device RCTs. Let's see if we can find some of those. In the mid 19, excuse me, the mid 20th century, which is the mid 1900s, when medical technology was expanding rapidly, early randomized trials were conducted on dialysis machines and cardiac pacemakers. And this is probably a time to throw a plug in for my short video series on clinical engineering prior to the Gilded Age and after the Gilded Age. You can learn a little bit more about the evolving and evolution of clinical engineering. But anyway, these studies helped establish not only whether the devices worked, but also how safe and practical they were in real world use. And the lesson that we bring today is just as streptomycin's trial became a model for drug evaluation, modern clinical engineers must think critically about how to structure trials before devices. Do we compare the new technology against usual care, against the previous generation of the device, or against the placebo like condition where the intervention is withheld? So RCT's history reminds us that clear, unbiased comparisons, whether it's something like citrus fruit, and I love lemons, antibiotics, or medical devices, these are the foundation of evidence-based practice. Critically appraising a study on interventions. So when we look at a study about an intervention, whether it's a drug, a therapy, a device, or a system change, we don't just accept the results at face value. We ask three core questions. Are the results of the study valid? Was the study designed properly? Was there randomization, blinding, a control group? Were biases minimized? In clinical engineering terms, was the trial of the new infusion pump or the imaging protocol or alarm system designed so that confounding factors were controlled? Or could other variables like staff experience or patient mix have influenced the outcome? What do the results show? What was the measured effect? Were the results statistically significant and clinically significant? Or were they practically significant? For devices, this might mean asking, did the smart pump reduce medication errors by a meaningful percentage? not just a trivial one? Did the new ultrasound probe improve diagnostic accuracy enough to change patient management? Can the results be applied to patient care? Even if the study is valid and the results are impressive, do they apply to my setting or my patient population? For clinical engineers, would a device tested in a large academic hospital work just as well in a small community hospital with different workflows? Would the new alarm system help in our ICUs where nurse to patient ratios are different? The takeaway is this: critical appraisal is about more than reading the abstract. It's about asking, was the study well done? What did it really find? And can I use this evidence in my own practice or institution? Determining whether study results are valid. So, when we critically appraise an intervention study, the first thing we ask is whether the results are valid. To do that, we look at how the study was designed and carried out. Some key questions could be: were the experimental and control groups similar at the start? Did both groups begin the study with the same prognosis? If one group had sicker patients than the other, the results could be skewed. Was randomization used? So, were patients randomly assigned to the treatment or control group? Randomization helps ensure groups are comparable. So, was randomization concealed from the clinician? So, if the clinician has any influence over which patients get which treatment, bias can creep in, sometimes unintentionally. Concealed randomization keeps the trial fair. Was an intent to treat analysis used? This means patients were analyzed in the groups they were originally assigned to, regardless of whether they finished the treatment. Without this safeguard, results can look better or worse than they really are. So the next thing is, were the groups truly similar? Sometimes, despite randomization, groups end up in a little different. They end up looking a little different. Say one group has more patients with advanced disease. If that happens, it raises a question about the study's validity. And again, if we can flip the script here to clinical engineering, the same principles apply when evaluating new medical devices or technologies. And again, I'm keeping these examples as basic as I can, so that because this might be a new topic to you all. But if we look at baseline equivalencies, if you test a new infusion pump in one ICU and keep the old pumps in another, but the two units have different patient acuities, it's hard to know if differences in error rates are due to the pump or the patient mix. So, randomization: suppose you're evaluating a new ultrasound probe, randomly assigning patients to either the old or new probe helps reduce bias. If sonographers get to choose, they might unconsciously use the better probe on the easier cases. So, concealment is also important. In device trials, if engineers or clinicians know which unit is using the new system, their behavior may change in ways that bias results, which is the Hawthorne effect. Concealing assignment helps reduce this. So, intent to treat in devices. If patients randomized to the new ventilator group are later switched back to the standard ventilator, they should still be analyzed as part of the new group. Otherwise, results will be misleading. And the key point is, whether you're studying drugs, therapies, or devices, the validity of the study depends on making sure the comparison groups are fair, random, and free from bias. Once a study begins, we also need to check whether the experiment and control groups remain comparable throughout the trial. And so here are some key questions. Did the groups retain a similar prognosis after the study started? For example, did one group end up dropping sicker patients while the other did not? If so, results could be biased. Were participants aware of their group assignment? If patients know whether they're receiving the real treatment or not, their expectation might influence the outcome. This is why blinding is so important. Did clinicians or assessors know the group assignments? If doctors or outcome assessors know who is in the treatment group, their judgment can be influenced, sometimes unconsciously. That's why we try to keep assessors blinded to allocation whenever possible. For example, of a surgical trial, the surgeon obviously knows whether they performed the operation, but outcome assessors, those rating recovery, imaging, or quality of life, can often still be blinded, and that would help. And the next question is, was follow-up complete? So if too many patients are lost to follow-up, the results can't be trusted. We need to know what happened to nearly all the participants, not just the ones who stayed in the study. And going through clinical engineering, these same issues matter when evaluating devices and technology interventions. So maintaining comparable groups. Again, comparable groups here and comparable groups with patients. If one ICU with the new smart pumps, the new smart alarms, has higher staff turnover during the study, that could affect outcomes and biased results. And if we look at blinding participants, patients might not know if their imaging study was done with the new ultrasound probe or the standard one, and that helps reduce the placebo or expectation effects. We can also make sure that we blind the assessors and think of radiologists reviewing images from two different ultrasound systems. They should not know which machine produced which images. Otherwise, brand reputation or personal bias could creep into their interpretation. And again, this happens to everybody. Just ask one of your friends who loves a particular automobile why they actually love a particular automobile and why they think it's better uh, because of a brand. So let's look at the complete follow up. If half the cases logged on a new infusion pump are missing due to poor data capture, then the trial's conclusions are unreliable. Device evaluations need complete usage and outcome data. A key point is good trials don't just start with similar groups. They stay fair and unbiased throughout with careful attention to blinding and complete follow up. Looking at the results of a study. So once we're confident a study is valid, the next step is to look closely at the results. And there are two major issues here. First is how large was the treatment effect? Did the intervention actually help? We measure this using concepts like relative risk reduction or R, and sorry, I had to do that, and absolute risk reduction, as Robin Williams would say, RRR. And so RRR tells us how much risk was reduced proportionately, while ARR tells us the actual difference in outcomes between the groups. And so the next thing to ask is, how precise was the treatment effect? Were the results statistically significant? What do the confidence intervals and p-values tell us about the reliability of the findings? A small p-value suggests the effect is unlikely to be due to chance, but confidence intervals show us how wide or uncertain the estimate really is. And one thing when we talk about statistically significant, when you're dealing with issues like this in real time, it may not be possible to have a large study. And sometimes we have to deal with what's called practical significance. And again, I'm not talking about that here today, but just another term that you should be familiar with for industry when you're dealing with smaller sample sizes. um, so let's talk about applying the results to patient care now. So once we understand the size and precision of the treatment effect, we ask, can these results be applied to my patient? If the study population is very different from my patient's, generability may be limited, right? Um, were all clinical important outcomes considered? Even if a study has a primary outcome, we want to know if secondary outcomes were measured too. For example, a treatment might improve survival but reduce quality of life, or vice versa. Do the benefits outweigh the harms and costs? Every intervention has trade offs. It's essential to weigh the reported benefits against the potential side effects, the potential risk, and even financial costs. One weakness of many RCTs is that they may not fully capture adverse effects. That's why careful analysis of harm reports is just as important as measuring benefits. Within clinical engineering, right, the treatment size effect can be looked at as, let's say you have a new alarm management algorithm that reduces non-actionable alarms by 20%. Is that a relative reduction? So 20% fewer alarms compared to baseline? or an absolute reduction from 100 alarms per day down to 80 alarms per day. ARR may sound less impressive, but it tells us the real world difference. So let's look at precision of results when we're talking about clinical engineering. And let's use the example of the ultrasound probe. So if an ultrasound probe trial shows improved diagnostic accuracy but has wide confidence intervals, the effect may not be reliable. Clinical engineers should always look for how precise the findings are, not just whether they're statistically significant. And then, as I mentioned before, generalizability. A device tested in a large teaching hospital may not work the same way in a small community setting with different workflows. Engineers have to ask, would this device benefit our specific patient population and staff environment? So, all outcomes considered, a smart pump trial may focus on reducing medication errors, which is the primary outcome. But what about nursing workload? And what I mentioned before, cognitive load as well, alarm fatigue or downtime. So these secondary outcomes matter when deciding whether to adopt the technology. We need to look at benefits versus harms and costs. So let's take an example of a new imaging system. So you have a new imaging system, and it might improve diagnostic precision slightly, but at 10 times the cost. A new ventilator feature might reduce one type of error, but introduce new usability risks. Just like drugs, devices require a benefit risk cost balance before adoption. And the key point here is that understanding results is not just about did it work, but about how well it worked, how reliable the findings are, and whether they matter in real world patient care and device use. The Women's Health Initiative. A number of famous RCTs come from the Women's Health Initiative. So before WHI, random controlled trials were published. They published many observational studies that suggested that postmenopausal women using hormone replacement therapy, there's a lot of acronyms here, HRT, which is an estrogen and a progesterone regimen, had lower overall mortality and lower rates of heart disease. But there was a big problem with this. The RCTs and observational studies were giving conflicting results. The original Women's Health Initiative randomized control trial became the turning point. It showed that the HRT did not provide the expected benefits. In fact, it revealed possible harms, including increased risk of breast cancer and cardiovascular disease. So, when researchers went back and reanalyzed the early observational studies, they discovered a hidden confounder. Women of higher socioeconomic status, who were generally healthier to begin with, were more likely to use HRT. Once these differences were controlled for, the apparent benefits of HRT disappeared. The lesson is that sometimes interventions look promising in observational studies, but only a well designed RCT can settle the issue. Again, we need to always conclude this to the other side, which is the clinical engineering side. If we can have a similar situation happen with medical devices and technologies. Again, I'll try to keep the examples very basic since we're being introduced to this topic. But if you look at observational bias in device adoption, so for example, a new infusion pump or alarm system might first appear safer in observational reports, but often these early successes are from like high resource hospitals with strong safety cultures and well trained staff. And this can make the device look more effective than it really is. A random controlled trial style device trial, if we perform that, it'll look like a multi center RCT that might later reveal that the device doesn't reduce errors or even introduce new risks when used in typical hospital settings. So some of you with backgrounds in biomed and clinical engineering probably have stories of clinicians' bias in practice to a particular model or a particular device, brand. Um, so let's continue with the examples. So early observational studies, again, of smart IV pumps suggested big drops in medication errors, but large-scale controlled evaluations showed that without proper implementation and training, the benefit was far smaller. The benefit in early adopter was partly due to those hospitals already having stronger safety practices. And the point is, just as with HRT, early observational results can be misleading. Clinical engineers must look for strong evidence and RCTs or well-controlled studies before concluding a device or technology if it truly benefits patients. And that first one, the adoption of new technology always has a steep learning curve, those who are in technology management. So we know that initial studies with the early adoption of devices is probably not the best place to conduct it uh, since it has what's called a high mortality rate, not as in people mortality, but as in device failures. And the device failures could be may not be due to the device itself, but to improper training. Um, Helicobacter pylori and gastric cancer. So not all RCTs overturn medical practice. Many confirm true benefit. So one powerful example comes from a study of Helicobacter pylori, bacteria that infects the stomach and is linked to gastric cancer. Researchers asked if we eradicate H. pylori, so if we eradicate this in patients with gastric cancer, can we reduce the risk of reoccurrence? The intervention was a combination of antibiotics to kill the bacteria, and the results were very, very clear. There was a 66% relative risk reduction, so a two-thirds drop in gastric cancer recurrence amongst those treated. And this RCT provided strong evidence that treating H. pylori with antibiotics could save lives by reducing cancer reoccurrence. And in clinical engineering, a similar type of benefit has been shown in device-based interventions. So ultrasound guidance for central line insertion. So again, for decades, central lines replaced by landmark techniques. Then RCTs tested whether ultrasound guidance could reduce complications like arterial puncture or pneumothorax. And the results were, again, striking. Ultrasound reduced complications and improved first pass success rates. And this was a clear patient centered benefit. It's similar to in strength to the H. pylori finding. And the key lessons here for engineers is that when evaluating devices, look for large, meaningful reductions in risk, both absolute and relative. So a relative risk reduction of two-thirds is powerful, but engineers should also ask, what does that mean in absolute terms? How many complications are prevented per 100 procedures? And the takeaway is that RCTs can provide overwhelming evidence for interventions, whether antibiotics for infection or ultrasound guidance for procedures, making them the gold standard for improving patient care is critical. So, in summary, the most common type of question in evidence based medicine is about intervention, sometimes referred to as treatment or therapy. And the best evidence for interventions comes from randomized controlled trials, RCTs, or even better, from systematic reviews and meta analysis that combine multiple RCTs. These studies help us separate real effects from bias. It just shows us which interventions truly benefit patients and which ones may cause harm. So, for clinical engineering, the lesson is pretty clear. Devices, technologies, and system changes must be held to the same standard of evidence as drugs and therapy. RCTs and well designed studies allow us to evaluate whether a new pump, alarm algorithm, imaging system, or monitoring tool actually improves patient outcomes, or whether its benefits are overstated. Evidence based practice means making decisions that are rooted in tradition, not in tradition, excuse me, that are rooted not in tradition or assumptions or marketing, but that are rooted in high quality evidence that balances benefit, risk, and costs for real patients. That is the end of this session. Again, I want to thank you very much for giving me your attention for the last 40 minutes, and I will see you in part 4 of this series on evidence based medicine.